Thank you very much, Dr. Adnanu, for the interesting presentation. And we'll move on to the next presentation by Dr. Ahmed Elmaiah. He will present a review of the current management of Paget-Schroeder syndrome.
Thank you, Mr. Chairman. I'd like to present current management of Paget-Schroeder syndrome. Upper limb DVTs account for 10% of all DVTs. Usually it is secondary to other causes. When thrombosis of the axillary subclavian vein is associated with thoracic outlet syndrome, it's called Paget-Schroeder syndrome. Other names, primary effort thrombosis. It is quite uncommon. Incidence about 1 to 2 in 100,000 population. Age from adolescents and young adults with male predominance. About 30% are young athletics. The anatomy is interesting in this topic because there are, in the venous thoracic outlet syndrome, there are two areas of compression. One at the anterior part of the first rib as the vein crosses over it, where it is surrounded by the costo-clavicular ligament, subclavius muscle, anterior scalene muscle, and first rib. Any apparent anatomy will cause compression on the vein. Another much less common is as it passes below the subclavian of the pectoralis minor insertion. The pathophysiology, repetitive upper limb movements, especially with putting the hand above the head, or jerky movements will cause micro tears in the venous endothelium, which can predispose to venous thrombosis. Another pathophysiology comes from only extrinsic compression in the non-thrombotic cases. So according to the SBS reporting standards, the diagnosis of painful swollen discoloration of the upper limb after exclusion of secondary causes. When the symptoms are fixed, it is suspicious for subclavian venous thrombosis. And when it is only positional with arm abduction above the 90 degrees stress position, it's called McLeary syndrome. On examination, the dilated venous collaterals, Orschel sign. Also, the discoloration, visible ulnar swelling, and rarely bruine. Laboratory investigations limited the emergence thrombotic cases. Thrombophilia needs to be excluded. And in duplex, while the conventional venous venography is the gold standard, duplex is the first initial test where the vein is diagnosed to be, when the vein is occluded, it's a diagnosis for thrombotic one. But when the vein is patent with abnormality either at rest or during stress position, is diagnostic of the non-thrombotic one. The CT and MRI venography are reserved for thrombus localization and identification of anatomical variation. So principles of treatment for thrombotic one, standard anticoagulation as early as it's found, catheter-directed thrombolysis, corrected on anatomical abnormalities, and prevention of recurrence. Anticoagulation is pretty standard. It's already already well covered in the previous presentation for the pediatric consideration. Together with involving MDT. The catheter-directed thrombolysis is targeted to be done within the first 2 weeks of presentation to be effective. You can see the photos here. The first one is the immediate. The first one is the thrombolysis, day 1 and day 2, where it brings back the vein to square one, where you can see some disease at with the vein kinks over the subclavian vein, which needs to be addressed as we'll discuss now. Up to 6 to 8 weeks still affected at the expense of the patency and success of the procedure. Surgical decompression is an essential part for this condition where because the rationale for this is that the rethrombosis rate without addressing the underlying compression and doing external hemolysis with the section of the scar tissue around the vein, which are essential to increase the long-term patency and decrease the thrombosis rate. The first approach is the infraclavicular approach, which is done either by itself or together with the supraclavicular approach, or the paraclavicular approach, where you can do the good access to the anterior part of the first rib, as well as the doing the venous reconstruction, which can be facilitated by the supraclavicular approach to facilitate access to the inner side of the vein, the medial side of the vein. And interestingly, there is an anterior venous fistula maybe need to be done for a few weeks to keep the reconstruction open. The transaxillary approach is claimed to be the easiest. However, it is difficult to do venous reconstruction with it. That's why it is associated with usually with venography, and you can do angioplasty and stenting. So it's reserved for patients who was non-thrombotic one, who would have no expected disease after the first rib resection. Angioplasty alone and venous stenting, while they may have an initial good success, but the primary patency is very poor. Generally speaking, stenting is contraindicated without prior decompression. There is good results, especially with the dedicated venous stents up to 100% after decompression in some reports. Afterwards, pain management, sleeves, physiotherapy rehabilitation, and long-term follow-up with close duplex surveillance. This is a summary of the management. Looking at the current evidence level, there is no randomized control trial about this topic at all. All the papers are retrospective studies, and you could only found 3 meta-analyses in the last 5 years. Looking at the current guidelines, there are some areas of controversy, of consensus, but there are more areas of controversy. For example, the rule of prophylactic contralateral decompression when you have a disease on one side, with certainly guidelines variability. This is one of the meta-analysis done, one of the latest meta-analysis done on 2,653 patients. And you could see a superiority of catheter-directed thrombolysis plus first rib resection compared to single or dual modes of treatment. And even the comparative effectiveness favors the catheter-directed thrombolysis plus first rib resection. There are more emerging technologies for robot-assisted decompression, first rib resection, mechanical thrombectomy, and bioresorbable stents, but certainly more clinical trials are needed. That's my references. So in conclusion, time is critical. Early cognition and management within the 14 days is essential, maintaining a high index of suspicion, especially in young athletic adults. It certainly requires multimodal, more than one treatment option. Simple anticoagulation or simple catheter thrombolysis is not enough. Incomplete procedures will lead to high recurrence, and afterwards, rehabilitation, appropriate anticoagulation for duration, and close duplex surveillance is essential to prevent complications and maximize functional recovery. Thank you.
Thank you very much, Dr. Ahmed, for the interesting presentation. Any questions before we move on to the